Now, can you guys see my screen? Are you okay?
Yes, Prof. Yes, very clear.
Yeah, I had discussed with you, Satya, and I wanted everybody to know that the course that we shall be doing this time is therapeutics. And what it means is that everything is the same. The drugs are the same, but the focus will be different this time because we shall be generally looking at therapeutics. Okay. So our focus this time would be, unlike third year, we will be looking at specific items like the choice of drugs, which shall be kind of simulating like patient conditions. We shall look at which is the first line choice of drugs, which drugs would be contraindicated for a condition, which drugs would be contraindicated, etc. And so this time it's not like last time. That means you have to go in deep. You have to take more depth to look at the drugs, like the adverse effects, the pharmacological parameters, etc. All right. Are there any questions up to that point? So we'll generally be looking at the same drugs, but the focus this time will be different. So we'll start with the first slide. Here is really nothing much. It's basically what we learned in third year. The drugs that we use for CNS disorders, just a brief introduction. The mechanisms of action is the same. Along the way, I will be emphasizing on the areas that I want you to remember in terms of therapeutics. Now, in terms of neurotransmitters, I want you to again revise and understand the main difference between ionotropic receptors, which are ligand-gated channels, and metabotropic receptors. At this point, I want to ask a question. I hope you can all hear me.
Yes, yes, clear.
I would like somebody to take me through the difference between ionotropic and metabotropic receptors.
Maybe Prof, I can try.
Yeah, go on.
So ionotropic receptors, as you've said, these are ligand-gated ion channels. So when the neurotransmitter is attached to the receptor, it leads to the direct opening of the ion channels.
Okay.
But for the metabotropic,
so what is
so
when you have the opening of the sodium channels, what happens? Of the ion channels, what happens?
So when there's opening of the ion channels, we have movement of ions, for example, sodium and potassium. So and that leads to what do we call it? Initiation of the required response. Sorry?
Which drugs employ this kind of mechanism? Ionotropic receptors. Can somebody help
give an
us?
example of epinephrine, for example?
No. Epinephrine would not employ that. Can we have somebody else take us through ionotropic? Can we have somebody else, please? So an example would be benzodiazepines. So benzodiazepines would act through this mechanism. So again, Satya, so when you have opening up, so which kind of channels what is the mechanism of action of benzodiazepines?
So benzodiazepines, we know they potentiate the GABA receptors, and they bind on the GABA receptors on the alpha whatever component, the GABA receptors.
Is it GABA A or GABA B?
Oh, GABA A, yes.
Okay. So when you have the binding, it leads to the opening up of the channels, isn't it?
Yes.
And then what happens after
and so
that?
There's an influx of the chloride ions.
So you have more of the more entry of what now?
The chloride ions.
GABA chloride. Okay.
Yeah.
Now metabotropic receptors. Can somebody help us on that?
I think someone else can talk.
Yeah.
Ian Malonde, I invite you.
I think if people are not, I'll now invite people at random. Can we have Miriam Farid? Miriam, can you hear me? Daniel Kivuva. What's going on? Abdulaziz Yusuf. Sorry?
So, Prof, let me try. Some are saying they're having issues. Their audio is not receptive. So for the metabotropic receptors, so these ones involve phosphorylation and dephosphorylation of the G-coupled receptors. So when that reaction cascade takes place, is what leads to the required response.
So what is the other name of metabotropic receptors? We have a name that is called system. What kind of system is this?
G protein coupled receptors?
No, that is what is here. But who is that?
Angela.
So Angela, what is second messenger system? Can you explain to me what second messenger system is?
The second messenger system is whereby the ligand doesn't directly activate the action, but it uses other molecules within the cell, which it activates to now effect the end goal action. There are different types.
So basically you have, you're right. You have a ligand binding to a receptor. Then you have a second messenger. You have a messenger, sometimes 2 or 3 even. You can have a transducer. So give me examples of those second messengers. Yeah, somebody else. There are several of those
calcium.
Yeah, you can have calcium channels. Yes, they could be ions. Others? Yeah, cyclic MP.
Inositol GMP.
So inositol triphosphate, yes, they could also be lipids, like which one?
Diacylglycerol.
Yes, diacylglycerol. So basically
And
that is second messenger system. So what happens in second messenger system is that the ligand that is binding to the receptor, the effect that occurs at the cell may have no relationship completely with the ligand. For example, epinephrine can lead to an increase in the breakdown of glycogen, like in sort of so that there is more energy, which is not a sympathetic nervous system. So it could be a different action altogether. Do we have any questions up to that point between ionotropic and metabotropic receptors? So let's quickly go through, excuse me, you guys, so let's go through the transmitters now. Again, they are the same. Again, I just want you to read the introductory part is not much, it's straightforward. So acetylcholine is one of the neurotransmitters. Later, we shall be looking at some certain conditions like Alzheimer's, which we have looked at. I'd like you to go through these receptors and understand their role so that when we get to the conditions whereby you have an effect on the on the nerves that encode for these neurotransmitters and the conditions, and you can easily understand. So the second one is GABA, which is mainly inhibitory. Again, we've looked at the action of benzodiazepines, etc. Glutamate and aspartate, NMDA is now a very important neurotransmitter in all CNS functions, like we discussed last time, including epilepsy. Glycine is inhibitory, important in toxicity, like strychnine. And then you have biogenic amines. These include dopamine that has a role in behavior. Acetylcholine has a role in behavior as well. And that's why we have, and drug enforcement. And that's why you have drugs that can be used to stop, like buprenorphine, that can be used to stop smoking, etc. The other biogenic amines, norepinephrine, again, regulation of anxiety, and of course, dopamine, norepinephrine, as well as serotonin have a role in CNS disorders like schizophrenia, etc. Histamine is excitatory throughout the CNS, and that's why antihistamines would cause sedation. Neuropeptides, enkephalins, endorphins, dynorphins, etc. Again, we've been through this in respect to pain management, etc. Tachykinins, as again, there are new drugs that are being developed that focus on these neurotransmitters. Are there any questions up to that point? So let's now go to the drugs. I'm having a bit of a challenge with, okay, let me try again. Is that okay now? Can you see the drugs? Satya?
Yes, we can.
Okay. Now, I think all of you can mute now. There's a lot of background noise. So maybe one of you only, the class rep or so, can, until I ask questions, I'll be selecting at random. Now, again, this is the same slide that we used last year. But like I said before, the focus this year is totally different. We will be looking at the same drugs, but we'll be having an in-depth, if you like, examination of these drugs or looking at these drugs in detail. So the first group are benzodiazepines. And again, like alprazolam, clonazepam, etc. What I want you to do this time is to critically look at all these drugs, the PK, the pharmacokinetic parameters of these drugs, which is fast acting, like alprazolam is fast acting, for example. So you have to look at the half-life. You have to look at the metabolism of each of them. How are they metabolized? Do they have active metabolites? And then the specific indications. Of course, the general indications, we'll discuss all of them. But this time I want us to look at specific indications. So that we say, for example, if we have a patient with generalized anxiety disorder, which benzodiazepine should we use, for example? And why would we use that benzodiazepine? Obviously, it's because it's related to the properties of that benzodiazepine. This is not midazolam, it's midazolam. Are there any questions up to that point? I want you to understand because the way we are going to examine you will be different this time. The drugs will be the same. So I want you to also look at the specific adverse effect of each of the benzodiazepines, not only the ones that we have listed, but all of them. So those are the benzodiazepines. And of course, flumazenil is used as a benzodiazepine antagonist. For barbiturates, the same. This time we're looking at the indications, the uses, the adverse effects, etc. The antihistamines that are used for hypnotic actions, these are just some of them. I want you to go through and tell us which ones we have excluded, for example. These Z drugs or non-benzodiazepine, different textbooks would use these drugs. These drugs, they would induce sleep, but they do not interfere very much with the sleep architecture. So in the same manner, I would like you to look at these drugs, to look at the adverse effects, which would be the choice of the use of these drugs. For example, Zalepton here would be used, for example, in patients who lose their sleep at night. So it would have short duration of action. So this time will be very, very specific on the choice of the drugs. So there you go, the other non-sedative drugs and non-sedating anxiolytic drugs, and that's like buspirone mainly. So looking at anxiety, again, nothing has changed. It's still, this is just a short overview. You will cover this in 5th year in detail, but mainly it's an adaptive response that prepares somebody to a threatening condition, characterized by changes in mood, that is fear, and of course, sympathetic arousal. If you're told there's a snake in the room, of course, you'll have a lot of apprehension. You cannot sleep. Or you are told there's somebody with a gun around your village, or there is a ghost. So all those are some of the situations that will lead to anxiety. Of course, there are several conditions that lead to anxiety, including some mental disorders. And one of the major manifestations of anxiety is insomnia. And therefore, one of the ways of management of anxiety is by use of benzodiazepines and this other group of. So this is just a very, very short overview. Acute anxiety, that's the presentation. Again, in 5th year, you look at this in detail. But at this point, I would like you to tell me which benzodiazepines you can use for acute anxiety. That's what I would be interested in 4th year. I would also want you to tell me which benzodiazepines, why they are suited for the treatment of acute anxiety. Is it because acute anxiety can be serious, and therefore would you require a benzodiazepine that is long-acting, short-acting, etc.? Panic disorder, again, you can use antidepressants, but the initial management is usually benzodiazepines and short to moderate acting. And the choices here are alprazolam and clonazepam. Again, apart from the short duration of action, are there any other considerations? So at this point, I would want you to tell me which is your choice, whether it's alprazolam, apart from clonazepam and alprazolam, which are the other benzodiazepines that may be used for this disorder. If we go to phobias, phobias, all of us have some form of phobias, but sometimes it becomes a problem. It's exaggerated. So we all have some kind of phobias, but when it is exaggerated, of course, it will require an intervention. You can use benzodiazepines, and you can also use antidepressants. So again, in 4th year, I would like you to go through your reading and tell me which benzodiazepines are indicated for phobias. For stage fright, of course, I think we discussed that last year. You can use propranolol, which one of the manifestations of phobia is, a lot of overexpression of the sympathetic system. And therefore, if you use beta blockers, then somebody can be more relaxed. OCD, obsessive compulsive disorders, characterized by, obsessions to something. Psychotherapy is important. We can use antidepressants, but we can also use benzodiazepines short term. So again, in your reading, I would like you to specifically look at which benzodiazepines. You can also read ahead of time and probably identify which antidepressants may be used for OCD. You know, clomipramine is one of them, and maybe we will need to understand why we would use those ones. General anxiety disorders, again, like all the other anxiety disorders, benzodiazepines are used for initial management. When it is a patient continues, then you have to use buspirone, which is important for chronic anxiety because it does not cause sedation. Okay, so that's why we use it in chronic anxiety states. Even then, at this point, I want you to tell me which are the adverse effects of buspirone. So if a patient is using buspirone for management of chronic anxiety, I would like you to tell me what are the adverse effects. You can also use SNRIs, especially venlafaxine. Duloxetine, you remember we use it mainly, that is marketed as Lyrica, is used for mainly for painful disorders. PTSDs, SSRIs are used, but not all of them. There are only 2 SSRIs. And at this stage, I want you to go through them and tell me which of these 2 SSRIs have been indicated for PTSDs. Benzodiazepines also have a role for PTSD, in mainly for treatment of flashbacks. You don't want a patient to remember an event that occurs that would has resulted in PTSD. Maybe they were in a traumatic event, like an accident or war, etc. Are there any questions up to that point? Don't worry, we'll go to specific benzodiazepines, which will be just an overview, but in your reading, I hope I've guided you. I would like you to be more specific this time. Any questions or comments? Okay, so the management of insomnia, this is usually self-limiting, like if people have a stressful event, etc. But if it continues, it may require intervention or treatment. Psychotherapy also has a role. So benzodiazepines are important drugs, but we have said that nowadays we use the Z drugs or Z drugs like zolpidem, Xalepton, Ramelton, etc., because they do not affect the sleep architecture. What do we mean by that? Again, can somebody help me on that? What do we mean by that? It doesn't interfere very much with the sleep architecture. Caroline Tabani. Who is unmuted? Everybody is muted. Agri Awajo. What do we mean by there's no interference much, that it does not significantly affect the sleep architecture? What's going on? Are you guys on?
Prof, I can try.
Yeah, but I don't want one person only. Okay, anyway, go on. Yeah.
I'm suspecting by not affecting the sleep architecture, maybe probably the sleep cycles and all that, now that the receptors are different this time. Not sure.
Maybe not. What do you mean by, can somebody else try? What do we mean by sleep architecture not being involved? So we're almost running out of time. So what we mean by sleep architecture, Satya, what time do you usually go to bed under normal circumstances?
10 p.m.
And what time do you wake up?
6 a.m.
6 a.m.
Yes.
So if you used like diazepam or a long-acting benzodiazepine, you will sleep fair enough, but what will happen? When will you wake up?
Probably at 10 a.m. and you oversleep.
You would oversleep, isn't it?
Yes.
So what we mean by sleep architecture is we want a drug when you have insomnia that you can take at 10 p.m., sleep after a very short time, and then wake up at 6 a.m., okay? So you are not interfering with the sleep architecture. In other words, you are not having insomnia again, you are not waking up early, or you are not waking up very late, okay?
Yes.
So that's important because it does not interfere with the day-to-day schedules of a person, okay? So can you imagine you have a student, for example, now with anxiety or even epilepsy, who is taking a drug that is sedating. It becomes a challenge, isn't it? Because maybe tomorrow they have a cut at 7 o'clock in the morning, okay? So it becomes a problem and it leads to depression, okay? So that's what we mean. So basically we need a drug whereby the patient would take the drug, sleep at the fairly normal time and wake up at the normal time whereby whenever they usually wake up. Okay, and then they do not have drowsiness after that. They can continue with their day-to-day activities. So the other issue is we do not want much tolerance and dependence like benzodiazepines, and that's why the Z drugs, they have tolerance but not, or dependence but not as much. Now about narcolepsy, of course, you would have to use CNS stimulants like coffee, etc. Enuresis, of course, we use the imipramine, which is antidepressants. And so all these conditions would either use CNS stimulants, antidepressants if they have insomnia, and psychotherapy as well as a role. Now let's look at the specific drugs. Again, this is last year's, nothing has changed. What is important here is, apart from these adverse effects that we raised last year, like anterograde amnesia, in other words, what youngsters call chewing a blackout, isn't it? You don't remember what happened, you know, like when you got a blackout. So that's anterograde amnesia. So that's exactly what happens with benzodiazepines. The other issue is respiratory depression. And they have anticonvulsive effects, and that's why they can also be used like midazolam, etc., for treatment of epilepsy. So these are some of the adverse effects: anterograde amnesia, respiratory depression, especially when administered as IV at high volumes, at high dosage, and then drowsiness. That's why they would interfere with the sleep architecture, would cause mild euphoria at low dose, and then they would cause physical dependence. On the use of pregnancy, again, like in our settings, obviously, it is purely an issue of looking at the case-by-case basis. You weigh the benefits versus the risk. So flumazenil, again, we've gone through that. This is to counteract immediate effects. So in terms of therapeutics in fourth year, this is now where I'm very, very interested in. I want you to look at those conditions that we had seen before, PTSD, etc., insomnia, muscle spasm, seizure disorders, and then especially for anxiety, I would like you to go back in your reading, look at the specific benzodiazepine that is indicated in any of those. This is just a quick overview, like we use diazepam and chlorodiazepoxide. These have long-acting metabolites, and they're used for alcohol detoxification, muscle spasms, spasticity disorders like cerebral palsy, etc. And the reason for that is for these conditions, you want the drug to act for a very long time. So here you are looking at the effect of the drug and the metabolite. So you want the effect to last for like 24 hours. Because like cerebral palsy and other spasticity disorders, the patient will continue having pain throughout. For anxiety, again, it depends on the kind of anxiety that you're treating with. Again, if it is panic anxiety, you may want to use prazolam. Generalized anxiety disorders, that's when now, here I've just given a short overview, but it's up to you. I would want you to now go and look at all of them and look at the specific indications. Midazolam, of course, may be used in anesthesia and also in the treatment of some in epilepsy as well. So alprazolam, this is a short-acting metabolite. So again, here we have indicated that it's used mainly in panic disorders. But if the condition is not resolved, then I want you to explain which other one we can use for panic disorder that we had mentioned before. Diazepam mainly for alcohol detoxification, but may have a role in anxiety as well. It's also used for spasticity and for many other degenerative disorders, like we looked at it last year, and even conditions like adverse effects of some CNS drugs. You remember we said if you use some drugs for a long time, you would get a condition. I want you to remind me which condition it is, and you would require to use a high dose of benzodiazepine, specifically diazepam. And so diazepam, so those are some of the conditions. It's widely used. We still use this drug in several conditions, especially in our settings. Oxazepam, temazepam, again, medium duration of action, and then anxiety and also seizures, that's in epilepsy. So please, during your reading in fourth year, I want you to specifically inform me what kind of anxiety that these three drugs are indicated for. Flurazepam, of course, has a longer duration of action, again for insomnia, but they are not first line now because they really interfere with sleep architecture. But if you have old people that fusion, delirium, etc., then that's why you may use it. But because of the adverse effects, which I want you during your reading to identify which are these adverse effects, why they have been banned in some countries. Clonazepam, again, we talked about management of West syndrome and, like in children, Lennox-Gastaut syndrome, etc. Midazolam, again, is used in anesthesia and in minor surgical procedures. And then we go to rohypnol. This is a drug that has a very long half-life, which we said mainly used for death trap and other conditions. Yeah, let me call you back shortly. Sorry. In terms of barbiturates, we don't have much time. I think we have like 5 minutes only. Again, barbiturates, they are mainly used in epilepsy because they are cheap and they are efficacious, but they would not be used for anxiety because of the adverse effects, especially respiratory depression and also porphyria. For patients who have that condition, they have predisposition to porphyria, so it's contraindicated in those patients. So mainly they're used in seizure disorders. Again, maybe during your readings, you may want to look at the specific adverse effects, although those are really fairly obvious. Thiopento, not very much used nowadays. You must tell me it's very highly lipid soluble and it is rapidly metabolized and eliminated within seconds. It's one of the drugs that is very widely distributed. Antihistamines, again, they may have a role in treatment of insomnia, especially, but they are not first line. But I want you to know that because histamine, like we said, is excitatory. So I want you to know the ones that we use. They were used also for inducing anesthesia. They were used in theater, but not very much nowadays. So Z drugs, to wind up, these are drugs that they act exactly like benzodiazepines. You will look at the mechanism of action, but they have few adverse effects, but they do not very much interfere with the sleep architecture. You can go through the adverse effects and again, specific indications. Like, for example, Zalepton is it? Yes, it has a short half-life and as an indication for patients who wake up at night and have difficulty in going back to sleep. Zolpidem, Sopriclone, again, are indicated for insomnia. So we don't use much of this. Melatonin, of course, you know the role of melatonin that's produced naturally. And they're mainly used, Ramelton mainly for jet lags, etc. Chlorohydrate is no longer used. So in terms of drugs for management of anxiety, the non-sedating drugs, we talked about beta blockers is short term, but the important drug here is buspirone for treatment of chronic anxiety. Now, I want you to tell me all the adverse effects, because if a patient has to use as chronic anxiety, this would be the first line drug. So I want you to tell me all the adverse effects associated with the buspirone and also drug-drug interactions. I forgot that. For all the drugs that you'll be looking at, you may want to look at the drug-drug interactions and which drugs they should not be co-administered with, etc. I think we'll stop there and I will invite questions now. Okay, in absence of any questions, can we meet on Monday afternoon or Tuesday? What time is convenient for you guys?
Yeah, Prof, I think Monday is okay with you.
Sorry?
If Monday is okay with you.
Monday afternoon.
Okay, fine.
Okay, fine then. All right. Have a nice day, all of you. So when are you reporting back?
In February.
February.
Uh,
Okay, fine.
yeah. So thanks, Prof, for your time. And also just for the others, we are recording the class. Kyoko is working on it in future to be easier so that we can record the classes in our YouTube link.
Yes, and what there are few areas that I mentioned really. We are using the same slides, but I said for those who checked in late, the focus is a bit different because here we are looking at therapeutics. We are looking at the adverse effects. We are looking at drug-drug interactions. We are looking at the specific properties that would help us in the choice of a drug, and then specific indications, etc. Okay, so that's what during your revision I would like you to look at all that.
And so, Prof, one more question: how many classes will you need for this?
Maybe 7 or 8 sessions. Maybe 7 sessions should be okay.
Okay. So
all
I
right.
think if you have 2 weeks as a class, we'll have to sacrifice.
Yeah, we'll just, because I'm also very busy, we will see when we can have time.
Okay.
All right.
Thanks, Prof. Okay. Good.
Okay, cheers.